Assalamu alaikum everyone. I hope everyone is doing well. Today we are going to discuss the dorsal column medial lemniscal system, one of the sensory pathways for transmission of impulses from peripheral parts of the body all the way to the somatosensory cortex and the post-central gyrus of the cerebral cortex. Okay, and for sensory pathways in general, we follow a scheme. Okay, we first discuss the type of receptors that will detect that particular modality of sensation. Still later, we will discuss its course all the way in the spinal cord till the cerebral cortex. This is the neuroanatomy part. Here we will cover this lecture in three parts. In the first part, we'll cover the neuroanatomy part. The second part will focus more on the clinical disorders that could arise in this pathway, resulting in problems with perception of those sensations. Okay, and in the third part we will have a shorter quiz that will be kind of homework for you to come up with. Okay, so we begin with the neuroanatomy part. So the name is self-explanatory, the dorsal column medial lemniscal system. To begin with, it is a sensory pathway for transmission of sensations of touch and pressure, vibration, and proprioception from peripheral parts of the body all the way to the spine, to the cerebral cortex. Okay, and the first part, like every sensory pathway, is the receptor part. Here we have a variety of mechanoreceptors for detection of these modalities of sensation, and there is significant overlap as well. And the confusing part is, even when we take them as distinct entities, as distinct sensations, there is considerable overlap in terms of causation. For example, the slightest touch with a cotton swab for a fraction of a second will amount to light touch, and that will stimulate a set of receptors. Okay, if we keep it there for some more time, it becomes sustained touch, and application of some gentle pressure will activate the pressure receptors as well. So this is a problem with this pathway is a similar stimulus and different intensities and gradations can cause activation of different receptors. And secondly, the confusing part is we have so many of them so that it is very hard to memorize them on individual basis. So here we have tried to oversimplify them in a way, like for detection of light touch, we have free nerve endings, okay, and we have hair end organs. These are neurofibers surrounding the hair follicle part of each hair, at the base of each hair. So whenever we have these lightest touch, possible touch, like touch with a cotton swab, okay, that will be detected primarily by free nerve endings and the hair end organs. Okay, in contrast, if that touch stays there for some time, it becomes sustained touch and or continuous touch, and we have Merkel's disc for detection of continuous touch, because the earlier ones we mentioned may get adopted readily, and the Merkel's disc will continue to detect that continuous touch. However, if we have a moving stimulus, we have a different set of receptors. Moving stimulus, like an insect crawling against the skin, will be primarily detected by the Meissner's corpuscles, and since it will be causing movement of the hair coming in its way, it will cause activation of the hair and organs as well. Okay. Similarly, we have Ruffini's endings in these subcutaneous tissues. If the touch stays there for some time and is deep enough to stimulate the pressure receptors, it will be primarily detected by the Ruffini's endings. Okay, and for vibration, if we go for the same oversimplified scheme, it is primarily detected by the Pacinian corpuscles and the Meissner's corpuscles, and the only difference is the Pacinian corpuscles will primarily detect high frequency vibrations, while the Meissner's corpuscles will primarily detect low frequency ones. Okay. Similarly, for the detection of proprioception, that is giant position sense, continuous awareness of the state of or different joints is primarily a function of the muscle spindles and the Golgi tendon organs. A change in the muscle length, say for example a muscle is contracting, its length is shortening. That change in length is primarily detected by the muscle spindles, while the tension that is created on the tendon is detected by the Golgi tendon organs. Now, at the same time, they act synergistically, and there is somewhat reciprocal relationship as well. We will discuss in appropriate. Well, activation of any one of these receptors will lead to generation of nerve impulses, and those nerve impulses will be transmitted all the way to the dorsal gray horns of the spinal cord through peripheral nerves. Okay, and those peripheral nerves have a certain design. Their cell bodies reside here in the dorsal root ganglia and the dorsal nerve roots of the spinal cord. Okay, and they are connected to the peripheral receptors through their peripheral axons. Okay, and from here, from their cell bodies in the dorsal root ganglia, they project their central processes that enter the gray horns of the spinal cord. Okay, here at this point they divide into a medial branch and a lateral branch. Okay, the lateral branch synapses with local neurons in the spinal cord. It is primarily responsible for generation of spinal cord reflexes. We will discuss in some other section. Here we are concerned about those medial branches, okay, of the peripheral nerve fibers. Those medial branches form a bunch of fibers that predominantly occupy this posterior part of the spinal cord and give rise to a bunch of fibers we call fasciculus gracilis. Okay. Now here there is one more thing to remember. This posterior part in the lumbar region is entirely occupied by the fasciculus gracilis because the sensory input from lower parts of the body enter the spinal cord in the posterior columns entirely through fasciculus gracilis. Okay. However, if we draw a diagram here, a gentleman, okay, the sensory input from the lower parts of the body, from the limbs, will enter the spinal cord at the level of the lumbar spinal cord and will reside in this area we call fasciculus gracilis. Okay. However, the sensory input from upper parts, the cervical region and the upper limbs, will enter the spinal cord and will predominantly reside in this medial part of the posterior columns we call fasciculus cuneatus. Okay, C for cuneatus, C for cervical region. Okay, from here these fibers ascend all the way up in the posterior columns, in the dorsal columns of the spinal cord till they reach medulla oblongata. Okay, and here till this level they ascend on the same side of the spinal cord. The first order neurons project in the fasciculus gracilis and still at a higher level fasciculus cuneatus on the same side of the spinal cord till they reach the medulla oblongata, where they synapse with neurons in the nucleus cuneatus and nucleus gracilis. The nucleus has a corresponding name. Fasciculus gracilis will end up in the nucleus gracilis. The fasciculus cuneatus will end up in the nucleus cuneatus. Okay, so if we draw it, we get something like this for the first order neurons. From here, we get the second order neurons which project from the corresponding nucleus gracilis in this case, and cross over to the opposite side in the medulla, the great sensory decussation. Okay, those fibers cross to the opposite side, ascend all the way to the pons and midbrain, and finally terminate in the contralateral thalamic nuclei, particularly the ventral posterolateral nuclei of the thalamus on the opposite side. So till this level, for the first order neurons, the ascent was on ipsilateral side, right for right, okay, and thereafter it ascends on the opposite side, okay, and from this is what we call the second order neurons, and from here the ventral posterolateral nucleus of the thalamus we have projection to the somatosensory cortex and the postcentral gyrus of the cerebral cortex, and that too is on the same side. We will cover the somatosensory cortex in some other lecture, but for the time being, I need to mention that somatosensory cortex is in the postcentral gyrus of the cerebral cortex, and it has a map of our body, different parts of our bodies, what we call somatotropic organization, okay, so that sensory impulses from my index finger will go to a region specified for that particular area, for the index finger in this part of the cerebral cortex. So that was about the neuroanatomy. Well, here I am fully aware of my shortcomings. I know the diagrams, the cross sections of the spinal cord at different level are not at least rectangular. The diagrams are a bit ugly, not that neat. So on YouTube, I could see, I found a few very good videos for those diagram parts, for explaining the neuroanatomy. I will put the link in the description. You can watch those videos for a better understanding of the neuroanatomy if you had any problem so far. If you are just okay with it, we can proceed to the clinical disorders part. If you are not, you better take a pause, watch those videos and with the link in the description, and then you can come back and join us. Well, here we discuss the relevant clinical disorders now. For the dorsal column medial lemniscal system to effectively transmit what it transmits, the touch, pressure, vibration and proprioception related information from the peripheral parts of the body all the way to the cerebral cortex. For it to be able to transmit this information, it needs to have all its essential components in a perfect order. Okay? Any problem with the receptors, with the peripheral nerves connecting the receptors with the spinal cord itself, or the cerebral cortex may cause impairment of this system. The whole system may collapse owing to failure of any one of its components. Well, we begin with the receptors first. Okay, we have a well-established disorder like pain insensitivity syndrome, where a problem with the pain receptors or pain transmission pathway results in impairment of perception of pain. But here, with dorsal column medial lemniscal system, we have very rare such cases. Okay, the literature, there is relative scarcity of data in literature about defects of receptors, and this is partly because we have so many of them. Okay, a defect with any one of them may be well compensated by all others because there is a significant overlap in function. Okay, however, there are certain acquired disorders where the receptors may suffer impairment, and accordingly the whole perception of all of these sensations may be impaired. I won't talk too much about that because that is going to be a part of the quiz. Okay. Secondly, the peripheral nerves that connect, that transmit the information, the nerve impulses from the peripheral receptors to the spinal cord are frequently affected. Okay, and we have many such cases. Any disorder affecting the peripheral nerves is what we call peripheral neuropathy or polyneuropathy. And among those, worth mentioning at this level are diabetes mellitus, the most common cause of peripheral polyneuropathy. In fact, in diabetes, whenever there is neuropathy, there is loss of vibration and joint position sense much earlier in the course of the disease. This is one of the first things to be affected in neuropathy and diabetes. Similarly, vitamin B12, deficiencies of multiple vitamins, particularly vitamin B12 and 6, may cause problems with the peripheral nerves and therefore problems with transmission of sensory information from receptors to the spinal cord. Okay. The third one is about the posterior columns itself. The dorsal column medial lemniscal system ascends in the posterior white columns of the spinal cord. Okay, so any anatomical or physiological problem with this part may also cause problems, and among these, the first one is subacute combined degeneration of the spinal cord. Here you may recall from your first year lectures that a significant difference between vitamin B12 deficiency and folic acid deficiency megaloblastic anemia is that vitamin B12 deficiency, in addition to causing megaloblastic anemia, also causes neurological impairment. Okay, it is the commonest cause to affect the peripheral nerves as also, but here at the level of the spinal cord, it commonly affects the posterior columns and the lateral columns here. Okay, and accordingly, if there is degeneration or whatsoever type of impairment of the posterior columns, the perception of all of these, particularly vibration, joint position sense, and pressure sense, may be affected. So wherever you find anemia with loss of sensations, particularly vibration and joint position sense, think subacute combined degeneration, think vitamin B12 deficiency. The second case is the posterior cord syndrome. Well, for any tissue to work, it needs to be alive, and the fundamental basis of life is blood supply, perhaps. Okay, so this part, the posterior part of the spinal cord, is supplied by the posterior spinal artery. Okay, so any problem with the artery itself or ischemia due to systemic reasons affecting the posterior spinal artery may cause degeneration or loss of function of the posterior columns. Ischemia causes necrosis. Okay, so that is yet another instance where we may have problems with the posterior columns and therefore as a whole with the dorsal column medial lemniscal system. Okay, the third case, tabes dorsalis. We need to share some history about tabes dorsalis. We need to have a sexually transmitted disorder with the name of syphilis. It is still there, but in the pre-antibiotic era, well before such advancements in diagnosis and therapeutics, we used to witness complications of syphilis. Okay, and one such complication used to be tabes dorsalis. Okay, now historically syphilis could affect any part of the central nervous system, including peripheral nerves, the spinal cord itself, the nerve tracts, the brain itself. But here again, this part, the posterior columns, used to be more vulnerable as compared to other parts. Okay, so the patient's tabes dorsalis means lightning pains. Okay, the patients used to experience lightning pains in the distribution of those affected nerves. Okay, similarly they used to have loss of pain sensation. They used to have impairment of vibration and joint position sense. Okay, and they used to have a problem with their gait, ataxia. So it used to be a whole complex, but at this level what you need to know, tabes dorsalis can affect the posterior columns. Okay, even though in the current era we see it very rarely. Okay, still later we discussed in the neuroanatomy part that during its course in the central nervous system, it gives rise to three sets of neurons: the first order, the second order, and the third order neurons. So during its entire course, okay, it may be affected by multiple problems. Okay, like its synapses with the gracile and cuneatus nuclei in the brainstem, in the medulla oblongata. Still later, it forms a bunch of fibers that runs as medial lemniscus. Okay, so during its entire course, if there are problems related to vascular supply, like loss of blood supply to any of those parts, will cause infarction, and accordingly this pathway may be affected. Okay. Similarly, trauma to any part of the central nervous system, particularly during its course, back trauma, head injury, etc., may cause impairment or interruption or impairment of the dorsal column medial lemniscal system. Okay. Similarly, tumors anywhere in the central nervous system, but particularly due in proximity to its entire course in the central nervous system, like in the brainstem, like in the cerebral cortex, may cause interruption of the dorsal column medial lemniscal system. So every component of this system needs to be in perfect order for this system to work effectively. A problem with any one of those may cause problems with the whole function. That is loss of vibration, joint position, or light touch and pressure sense. Okay. Well, here we move to the quest section. Here we have two multiple choice questions for you, and I wish you write down your answer in the comment section of this video. And at the same time, if you have any question, objection, or suggestion, you may paste it in the comment section, and we will try our level best to get back to you as soon as possible. Thank you.